Good morning. Today we're continuing the concept of mobility. Last week we studied mobility. We talked about herniated disc last week. We talked about osteoporosis and osteoarthritis. Let's recap and see what we remember from those. And what do you think is important to remember? If it's important to remember them, we have to remember them. Because when you're taking care of patients, there are things you have to do everything you're doing right. You don't want to ever be the one that will harm the patient. You don't want to ever be the one that the patient goes to surgery and comes back. Then you mess up the surgery. They spend 12 hours. No. Therefore, we have to know how to take care of our patients. We have to know how to reposition them. We have to know how to assess their wound. We have to know how to assess the whole patient and what signs and symptoms that are really very important to pay attention to. And when those, especially when those signs and symptoms are detrimental to the surgery or the side effect or the bad effect of the patient is receiving from that surgery. So for herniated disc, what do you remember? Please don't tell me anything about pathophysiology. Just tell me herniated disc. How does it affect the patient? And what do we do about that? Huh? They are in severe pain? Let's do it this way. Any problem you tell me, we have to follow it up with what? Intervention. Because if they have severe pain and they come to you for you to take care of them, they still have severe pain. Are we doing a good job? No. They came to us with the pain, therefore we have to intervene and send them home, hopefully without pain, or at least minimal pain. So they have pain. So what do we do for that? Give them pain medication. Which pain medication? Tylenol. What do we watch for the Tylenol? Liver toxic. Therefore, what do we educate them to do? No more than 4 grams. See how that goes. One thing leads to another, another. Therefore, patient is well-rounded when they leave and go back home. For pain. So what else? Eh? They have numbness and tingling in their lower extremities. So it's not unusual to come for back pain. Actually, we had a patient, not a patient, one of the nurses was telling me how she has back pain and her leg hurts all the time. So I had to educate her the connection between the two. She was like, wow, I learned all that in nursing school and I forgot about that. So it is not unusual to have back pain and you feeling pain in your lower extremity because of nerves. Remember, when you're having back pain, there's that protrusion that's touching the nerve endings. And when it touches those nerve endings, it transcends pain and stimulation and sensation to your lower extremities. What else? That was 2-hour class. Neurogenic bladder after surgery. So what do we do about that? What does neurogenic bladder after surgery mean? Huh? They're not able to void because of that lack of sensation. Because again, there's possibility of nerve damage during the procedure. So those patients tend not, the bladder is mostly affected. They tend to retain a lot of urine. They cannot feel the sensation to void. Because they don't feel sensation to void, they tend to hold a lot of urine. And when they hold a lot of urine, is that good for the patient? What does it predispose them for? UTI. That can even go all the way to kidney infection, not just urinary tract infection. What else? What about what else on herniated disc? Assess the incision site. Why is it important to assess the incision site? If it's cerebrospinal fluid, do we have to reinforce the dressing? If it's cerebrospinal fluid, do we reinforce the dressing? Anybody? What do we do? Call the doctor. Then reinforce. Cerebrospinal fluid is critical emergency. We have to always notify the doctor first. Because the doctor has to do something to close that area where this spinal fluid is leaking. If it's cerebrosanguineous fluid, you reinforce. Clear cerebrospinal fluid, you notify the doctor. Because it's a clinical emergency. Patient can have infection through that opening where the fluid is leaking, and it can predispose them to systemic infection, and they can die from it. So you don't have time to be wasted trying to reinforce it. You can't do nothing about it. Even when you reinforce it, it's still going to be draining. Therefore, you need to call the doctor so they can transfer the patient to surgery and seal the area where it's leaking out from. What do you think is the most important thing to do first after the patient comes back from surgery and they are stabilized? Huh? Assess their lower extremities. What else do we need to do? Ambulate. They need to ambulate. There's one doctor at Tulane who is a neurosurgeon, Dr. Syria. His patient has to get up. Get up immediately out of bed the same day of surgery. They have to get up. There's a reason why he does that. So all the nurses get nervous. Some nurses still don't even remember. Because we used to, the first day the patient gets out from surgery, only physical therapy can get them out of bed, not him. That patient has to get up. Because again, once they start ambulating, chances are they're not going to have those signs and symptoms that we have listed, right? It decreases their chances of having deep vein thrombosis, increases their cardiac output when they get up. Those signs and symptoms of immobility can be countered once they start getting up. So he knows what he's doing, and his patient gets well faster than most patients. Get them up, ambulate them, stimulate that, increase that cardiac output to increase oxygenation. That will bring food and nutrients to those areas where you have the surgery. Prevents them from having deep vein thrombosis. Increases their cardiac output. See, just ambulation, what it can do. Which if they don't do, it reverses all these two things, and the patient stays in the bed longer. Osteoporosis. Anybody? Anybody who hasn't said anything? Anybody who hasn't said anything? Osteoporosis, what do we learn from that? You see, you thought you were going to come here today and just sit and listen to me, see? I do ask questions. Osteoporosis is a metabolic process from lack of or decreased calcium in the bone. Because it's a metabolic process, it makes the bone porous. And it predisposes the patient to what? Fall, high risk for fracture and fall. And what do we do about that? Educate the patient on preventive measures so that they don't fall, how to clear their houses, make sure they don't trip on something. Educate them to take vitamin D and calcium, right? To increase that calcium that they don't have. Educate them on the foods that can help them increase those calcium and vitamin D. Educate them on the importance of exercise, because exercise strengthens bone and increases that absorption of calcium to help prevent them from having porous bones. So they need to exercise. Therefore, they need to do weight-bearing exercise, because it's only when you, not only, but weight-bearing exercise is most important for those patients that have osteoporosis, to be able to extract that calcium and build strong bones. Osteoarthritis, anybody? Non-weight-bearing exercise, because they usually have pain because of those bone rubbing on degeneration of the cartilages in the bones. Bone rubs on bone is very, very painful. Therefore, they cannot stand up to exercise. They need to do non-weight-bearing exercises like what? Swimming, cycling. Somebody sent me a lengthy article talking about, are these all non-weight-bearing exercises? Please stop sending me stuff like that. You want me to read an article to be able to sort out which one is non-weight-bearing? I thought I spent tremendous amount of time on that. Weight-bearing means you're standing on your lower extremities, bearing the upper extremity well. Weight. When it's not doing that, it's not weight-bearing. When you're cycling, you're not standing on your knee. When you're riding back, you're not standing on your knee. It's not holding the upper extremity. It's not bearing that weight. That's not weight-bearing. Weight-bearing is when the lower extremity is bearing the weight of the upper, which is what I'm doing now. Weight-bearing. That's the difference. Okay, continuing. Today we talk about ALS and what else? Multiple sclerosis. I'm not going to spend much time again on SLO because we did that in the beginning of this mobility. It's still the same mobility. So we still have to pay attention to our lab values, pay attention to our medication, collaborate with physical therapy and nutritionists, other auxiliary workers to be able to take care of your patient. Prioritize your patient care. Always pay attention to what the patient have, issue that they have. If they are having neurogenic problem, that means airway becomes important. Therefore, if they're having dysphagia, difficulty swallowing, airway becomes important. Prioritize their care so that they don't have complications if we don't prioritize them. In the nutshell, that's our SLO, because we spent time on that already in the beginning. So let's look at this right now. Where it is. Multiple sclerosis. How many of you know somebody who have multiple sclerosis or have taken care of a patient who have multiple sclerosis? You have? How does that, what happened to that patient? What brought that patient to the hospital? She has what? She has some bad days and some good days. They go into a period of exacerbation, and remission. What else? Anybody? They do have nerve pain. Anybody else have taken care? Difficulty to swallow. What is it called in medical terminology? Anybody? Dysphagia. Double vision. Coordination ataxia. Ataxia, inability to coordinate movement. Urinary retention. Constipation. Depression. Fatigue. Tingling and numbness. See, we finished the class. What else? Difficulty breathing. Shortness of breath. Okay. What did you say? Memory loss. Memory loss. What else? Very good. I like this. So, when we're looking at MS, multiple sclerosis, some people say it's an autoimmune disease that affects the central nervous system. It affects the nerves. In the nerve endings, we have what we call myelin sheath. Myelin sheath. What multiple sclerosis does is the immune system attacks this myelin sheath. The myelin sheath protects the nerves. But when the immune system, what it does, it attacks this myelin sheath that protecting the nerve. Because it attacks this myelin sheath, it will begin to damage the nerve around the myelin cover. As it begins to damage these nerves, it can be necrotic. Because it's damage to the nerve endings, it affects the neuromuscular systems of the body. So, MS, or multiple sclerosis, is demyelation of the myelin sheath. Demyelation of the myelin sheath means attack on the myelin sheath. The myelin sheath covers the nerve endings. Because it attacks those nerve endings, it predisposes the patient into multiple body system problems, coordination. It affects all parts of the body systems, the central nervous system, neuromuscular systems. So, as you can see, it causes all these signs and symptoms that you all gave me. It affects the body, the whole system. All parts of the body are affected because all parts of the body uses nerves to coordinate. So this myelin sheath attacks that. Patients that have multiple sclerosis, they are it starts off mimicking every other disease. You can imagine the frustration the family go to. The patient keep going to the doctor. They keep doing all kinds of tests. They will never find out what's going on with the patient. They go to different clinic appointments. It will make you feel like you're faking your disease. But you can tell that you cannot get up, you cannot ambulate, it's achy, you have neuropathy, you have pain all over the body, you have shortness of breath, you have a numbness in your lower extremity. Yet, nobody can tell you what's going on with you. That's frustrating. Sometimes it begins to mimic stroke because the patient will start being weak. It makes it look like a stroke, but when they do the test for stroke, it's not. So it is one of those diseases that nobody knows what causes it. Some people say it might be infection, it might be family related. They are not sure. And there's no specific test for multiple sclerosis. It's only diagnosed with the signs and symptoms the patient presents to them, which are these signs and symptoms that we listed, and even some more we're going to go over. So it has no test to prove that you have multiple sclerosis, and nobody knows what causes it. So it's very frustrating. It's only towards the end stage of it, towards the end, after the patient has been to the hospital over and over, that the doctor will say, okay, you know what, this patient has multiple sclerosis, and they will start treating the symptoms. So because it affects the whole body, the whole systems, those patients have everything you said, but let me reduce this so I can write some here. Of course, they have period of exacerbation and remission. So it affects the muscular or motor. It affects the motor system. It affects cerebral systems. It causes emotional problem for the patient. So it affects so many parts of the body. It affects cognition. They get confused. So we can add that here. Cognition. Confusion. They have ataxia, difficulty walking. They have numbness and tingling. They have diplopia. What is diplopia? They have double vision, diplopia. They have dysphagia. So, as you can, it affects different parts of the body. So, this patient might go through the period, they will be so confused, they are not coherent in their conversation. And it affects women more than it affects men. I have run into a lady in the clinic, an African American in the clinic. She told me she has multiple sclerosis. That's my first time seeing a patient with multiple sclerosis, or somebody with multiple sclerosis. She was walking with a cane, a young lady in her middle 40 or 50. I know I'm older than her at the time I saw her. I'm old, I guess I'm still older than her. So, she was walking with cane. So, it affects movement. That ataxia, they cannot coordinate their movement. So, they also high risk for fall. If they cannot coordinate movement, they can easily trip on something and fall. So, we have to watch that. Because also they have issue with feeling in their lower extremities, numbness and tingling, we have to watch that too. any numbness and tingling, patient is high risk for fall. Patient is high risk for injury. And when they have that injury, it might take a long time to heal because they don't feel it. Therefore, that means even if they have the injury, they don't even know they have that. By the time they seek help, they might be infected. So we need to educate them on that. They have double vision. What do you do for a patient that have double vision? If you go in a patient room and the patient say, I have double vision, what do you do to that patient? Huh? You have to cover one eye. Cover one eye. Guess how I knew that? The patient taught me that. Actually, the patient taught me that. I went in the room, the patient put a patch in the eye. I said, oh, did you have eye surgery? She said, no, I have blood vision. I have double vision. But when I cover one eye, I can see you. But if she can cover her eyes, she don't know that I'm there. She say I look like, she don't know if it's me on this side or on that side. Yeah. So what made them think you have MS? You see, that's what I'm saying. Vague symptoms. And nobody knows what it is because there's they don't know how to diagnose that. No test that can say, okay, definitely you have MS. They base that MS diagnosis based on signs and symptoms. So you see, I wasn't lying. So they have double vision, and double vision is not good because that predisposes the patient to fall because they don't know if the step is here or there or the floor. They don't know if they're stepping on the floor or not stepping on the floor. So that patient taught me that. I was like, wow. She said, now I put this on, I can see you. Otherwise, you were here and there. I don't know which one is really you. Isn't that strange? That is it can be, and this lady is young. You can imagine a young girl with that kind of vision, with that kind of problem. Somebody who will be out there looking for boyfriend or girlfriend or something. But this kind of thing confines them. So you're looking at the emotional. It can affect their emotion. That's that emotional aspect. You have to educate the patient on what's going on with this disease. Because they don't know what to expect. A lot of teaching on how to prevent injury becomes our main intervention. It affects the muscle. This patient, it affects the bladder a lot. The bladder can either be flaccid. What is flaccid bladder? Flaccid means that something is what? Just no form of elasticity to it, right? So when they have this flaccid bladder, they don't know the bladder is full. Again, it looks like neurogenic bladder. They cannot pee. They don't feel that it's full. That predisposes them to urinary retention. So with flaccid bladder, it can cause urinary retention. Again, for urinary retention, what do we do? What? Bladder scan and do what else? Bladder scan and do in and out based on the amount of urine that the patient is retaining, right? So what is the rationale for the in and out? If it's more than 300, depending on what the doctor wants you to do, but more than 300, I will be heading towards getting my catheter ready for in and out. Because you don't want that urine to cause what? Urinary infection for the patient. So it can be flaccid or it can be contracting too. It can be contracting. So this MS can do wonders to the bladder. It can either make it flaccid, whereby the patient retains a lot of urine that can predispose that patient into urinary retention. Or it can be having a lot of spasms or contracting, having spasms. When you have those spasms, what do you think is doing to the urine? Let's say, for lack of a better term, it's constantly contracting. Patient is having spasms. Will the bladder be able to retain urine? No, it's like any amount it retains is having that spasm. So it can predispose the patient to what? Incontinence, urinary incontinence. So it causes urinary retention and urinary incontinence because the patient cannot control that. It's having this spasmic episodes. So as it's having that, it reduces the capacity of that bladder. It reduces the amount of space that the urine bladder have to contain urine. So it can predispose the patient to urinary incontinence. Okay, so what have I said so far? Actually, I have finished MS, but you just don't know. We have finished that. So these two lines, what have you learned so far? If somebody who haven't said anything. Okay, very good. Because it affects women, or it could be men too. Anybody it affects can affect their social, how they deal with other people, and it can affect their emotional style. So we need to educate them on what to do. They need to join different groups that have MS. Some of these chronic illnesses or weird illnesses, they all have groups. There's always association for MS, association for any disease you can think of. They even have association for erectile dysfunction, association for people with HIV/AIDS. So it's good to join those associations so that you see you're not the only one. You might think you are the youngest. When you go there, you're going to see somebody younger than you. Or you might think you are the oldest. You go there, you see somebody older than you. So those things help patients to cope with all these illnesses that, are terminal or not common, rare occurrences. Okay. What else? This group here. I didn't tell you to have 5 people in your group. For somebody who haven't said anything out of the 5. There's no diagnostic test. It's basically diagnosed based on signs and symptoms. Okay? These 2 lines, you have like 200 people in your group. So, it affects all parts of the body. So, give me one example, not you again, what it does to the part of the body. Anybody? Blood vision, double vision, okay. This side. What have we learned so far on MS? It affects the bladder. How does it affect the bladder? This side here, this line. How does it affect the bladder? It can be urinary retention or they can have spasms, urinary incontinence. Okay, very good. See, you're paying attention. You act like you don't. Okay, so this paper that I gave you have, did anybody pick up this paper? One of these? Okay, we're going to do some exercise with that because that's in the nutshell. Oh, God, I printed this front and back. I don't know why I did that. That's in the nutshell about MS. So what we're going to do, just pick one side of it. I don't know. It may be double. What we're going to do is we're going to divide the class in half. Looks like it's skimpy on this side. So from this side, we do the right side of this patient, the right of the patient, this picture. This side, we do the left picture. I want you to pair up in groups of 4. In groups of 4 on this side to do the right. What are we going to do? We're going to look at these signs and symptoms and formulate interventions for them, for every single one of them, and pick somebody who's going to talk on your group. This group here will do the right side of this patient, which is this side. Groups of 4 each. Come up with these signs and symptoms and the intervention. This group will do the left side, which is this left side. Group yourself in 4s. Come up with these signs and symptoms and their intervention. The signs and symptoms are already listed in the pictures. So come up with the intervention, what we're going to do about it. We have 15, 20 minutes to do that. I want you to pay up. I don't want you to do it by yourself. Okay, so now we finish the group activity. Shelby told me something interesting, so I wanted her to share it with the group. So Shelby, what did you say?
and they've been trying to figure out what's wrong with them. So then they gave him the diagnosis of MS, but we still didn't understand. Like, we get frustrated with him because he takes so long to like answer a question, or like, hey, go grab this, and he like has to think about it. Like, it's just so slow. He's blind now in one eye, but some days he can go 100 miles a minute, and some days he can just lay in bed. But like he said, it's like a diagnosis that people don't know. Like, it's almost like you think that he's lying. Like, he can't get out of bed, but he really just can't. He's in so much pain that he just can't get out of bed.
So, you see how important it is that we have to understand what's going on with the patient. We have to understand these disease processes so we'll be able to know how to care for the patient. See, when she said that, I told her, no, don't tell me that. Let's wait so that everybody can hear that. It is a disease that nobody understood, but now she realizes that the stepdaddy is not faking it. Now she understands the disease because we're talking about it today, and she can relate to the family member that have these signs and symptoms. So now you can take it back to your family and explain to them, guess what? What the stepdaddy have is real. He's not faking this. He didn't wake up one day and say, I just don't feel like getting up in the bed, therefore I'm not getting up. There's something, it is the disease that's wearing him down. There are periods of exacerbation and periods of remission. So when this disease exacerbates, it affects the muscular skeleton. He cannot get up. He will feel very weak to get up. It affects cognition. They get confused. It affects eye movement. So now she can relate with what the stepdad is going through. This is the way nursing works, you know. We have to understand what's going on with the patient to be able to care for the patient. If we don't understand it, most often it looks like, that's why some nurses will say, oh, that patient calls too much. That patient worries people too much. They are not worrying people too much. There's something that's making them do that. They have signs and symptoms and diseases that's affecting the way they think. They have signs and symptoms and diseases that are affecting the way they walk. So you can't expect that patient to be getting up and jumping out of the bed, even though we're supposed to ambulate, without intervening to help them get up and ambulate. Give them pain medicine. We have to put warm or cold, do that, to be able to help them. If you don't understand the disease process, then it becomes difficult to care for the patient. So I like that story. I like that. So now, after the group study, I need one person in every group to tell us the area that you worked on. So let's start from this side. Let's start from this side. What did you discuss about? Talk loud so that they can hear you.
Incentive spirometer, turn, cough, deep breathe, if they're at risk for aspiration to suction and to increase fluids.
Okay. So that's the diminish for cough reflex. Turn and deep breathe. They have complications because if they don't turn, cough, and deep breathe, they're going to have issue with what? Infection like pneumonia. Okay, very good. What else? The other group, what did you discuss about? Okay. Elevate the head of the bed using scenting spirometer. And what else did you say? And breathing technique. Very good. So what else do you have? It doesn't have to be on the same one. What about urinary? Somebody else. Urinary, hesitancy, frequency, retention, bladder scan is your intervention. Okay, what else? Daily weight, I know, pericare, bladder exercise, we call it Kegel exercise, K-E-G-E-L, Kegel exercise, tighten. Why are you laughing? Well, yes, it will. You are tempting. Just educate it to them. Just educate it to them. Kind of like she said, by them not feeling their bladder move, feeling their bladder, will Kegel exercise help? Will they be able to do it? Yes. Because you still want them to be able, everything to come back to normal. Yes, you still educate them on how to do Kegel exercise. All that is an attempt to help them see if the bladder will improve. We can't just say, oh, they're not going to be able to fill it, therefore we won't do anything. Otherwise, there will be no need for rehab. The whole rehab is to rehabilitate those areas that the patient cannot do things with. You try to rehab that so that they will be able to improve and start working on it. And I have seen a patient who don't talk, they come to rehab. By the time they finish with speech therapy, they're able to make sentences. I have patients who cannot move their arm at all. They come to rehab, before they leave, they're able to use their hand to work with walker or care. So we can't just say, oh, well, they're not going to be able to feel anything, let's just not do nothing. You still need to educate them on how, making sure. It's all about tweaking the brain. If you don't tell the brain what you want the brain to do, it's not going to do a thing. That's why if you don't use it to do what? Lose it. So you still have to be telling the brain, look, I still need to pee, so let me try to do this. You still have to educate the patient. Yes, you still do that. So that's a good question. Okay, what else? GI, okay, so what will you do? What are the problems they have for gastrointestinal? Difficulty what? Chewing, dysphagia, bowel incontinence, constipation. So, difficulty chewing, what are you going to do for that? What is your intervention? Mechanical soft diet. Dysphagia.
Speech therapy.
Get speech therapy involved, because it is speech therapists that will evaluate the patient and check them for swallowing. So that speech therapy will be able to tell you what kind of diet the patient will be on. Either mechanical soft with thin liquid, where they can just drink regular water, or mechanical soft with thick liquid, where you thicken the liquid. So you cannot know all that until speech therapist evaluates the patient. And then what else do you do for dysphagia patient? Elevate the head of the bed up, right? That would be a good idea. You can put suction at the bedside. Mouth care, oral care. Because believe it or not, oral care is one of the 4 signs of infection for the patient. If you don't give them oral care, they might develop pneumonia from that, just from poor oral care. Patient can actually have endocarditis from teeth problems. So clean their mouth with swabs, not alcohol based, regular swab. Brush their teeth, clean their mouth before they eat, so at least they can have the taste of the food. Okay, good. So what about musculoskeletal? Oh, bladder incontinence, where we did Kegel exercise. Constipation, what do we do about that? Stool softener, colas, exercise, increase fiber, right? In the diet, fruits and vegetables, fluid, increase fluid. She said, teach them how to do enema at home. I don't think you want patients to be going home and be doing enema. That's just something elderly people do on their own. We don't really like to send patients home and teach them how to do enema. But we can do stool softener. We can do milk of magnesia. We can do Miralax, those high fiber stool softeners. We can do those, but not necessarily enema. Because some of these patients, it can cause vagal what? Stimulation. Some of these people have a lot of chronic illnesses. You don't want to stimulate vagal. Add to that. Anything else on this right side? Musculoskeletal. What are we going to do about that? They are fatigue and limb weakness. Allow for periods of rest between activities, right? Ataxic movement. Assist them with device that can help them to ambulate, clear the hallways or the areas where they walk so they can trip and fall on something. Bed alarm for those patients because they might be trying to get out of the bed because it's uncoordinated. Tremor. Physical therapy, consult physical therapy so they can help them ambulate. They can use special spoon for spasms. Again, occupational therapy. We work with them on that. Occupational therapy are the ones that help the patient with upper extremity first. They can help them fix their spoon where they have something to hold on to. These are the patients that we eat more like fruits, something they can just grab and put in their mouth. Try to eliminate a lot of stuff they have to hold spoon from. So something like bread, sandwich, they can do that. Cut off extra things that they need to do, like they have to hold the fork to get the food, spoon. Give them sandwich. They just grab the sandwich straight to their mouth. Carrots, things they can eat like that. Something simple. Okay. Dragging off. Dysarthria with slurred speech. What is dysarthria? Arthria, articulate. Dysarthria, difficulty articulating words. So, give them time. Do not hurry them. Give them time to come up with their words. If they can write, give them paper to write if they're not having too much spasm. Don't hurry them. Stand in their face so they don't have to turn around looking for you. Remember, they already have issue with diplopia. So give them something to write on. Talk slow. They don't shout. They can hear. They're not deaf. Don't shout. Face them face to face. Talk slow. Give them time to respond. Okay, what we're going to do, we're going to have 10 minutes break. When we come back, the left side will go over there. Okay, let's continue. Let's continue. So, the left side, neurogenic, neurologic problems. So, what are they and what are you going to do about it? Emotional liability. What are you going to do about that? This side. Group therapy, joint support group, medication, it can lead to depression, yes. What are the signs and symptoms? Forgetfulness and apathy. What are you going to do about it? Keep the same routine, keep the same nurse with them if possible. Reduce stimuli. Have them make lists. Reorient them when they are disoriented. Scanning speech. What is scanning speech? To scan speech means they cannot come up with what to say. Instead of saying, reach me this water, they can say, reach me. Then just break between that and water. They scan their speech, they're thinking what to say next, how to call things. So that's what scanning speech. So that means, again, you have to give them time. Don't hurry them, right? Give them enough time to communicate their needs to you. Impaired judgment and irritability. Now you know why your stepfather is irritable. He has all these signs and symptoms going through his body. He's going to be irritable. How old is he? Probably middle age. See what I'm saying? I'm way older than him. So middle age, you know. So that's very miserable. Let them vent, yeah, let them vent. Don't suppress them. Let them vent. Listen to them. You know, don't force back. Now you understand what's going on with them. It'll be easier to tolerate. But when you don't know what's going on with the person, you'll be running away from them because the next thing they start forcing for stuff you didn't even do. But now you understand that it's part of the disease process that will make it more tolerable for you to pay attention to the patient. Potential complications, seizure or dementia. Of course, give them medication. Make sure the environment is free of injury, something that they can hit their head on or fall. Okay, what about sensory, visual, blood vision, diplopia? What are you going to do about it? What did you come up with their intervention? Cover one eye. Safety. Safe environment. Make sure they have eyeglasses or whatever the doctor recommends for them. Change font size, make it letters, alphabet a little bigger for them. And these are the type of patients they need to go to bed just for sleep and sex. That's what book says. sleep and sex, instead of laying down in the bed, playing in the laptop, or laying down in the bed, watching TV, they need to associate bed with sleep. Things like that. Or sex, according to the book. I didn't make them up. What is nystagmus? What is nystagmus? Rapid eye movement. Again, that tells you again, everything keeps going to the eye. Safety becomes important. So this is not somebody patient you're gonna just leave food on the table and walk away. They may not even know the food is there. If they're having double vision, there's tray in their face, there's another tray on the left side. They don't know which one is the real food. So we have to make sure we have patience with these patients. Put the table in their face, cover their eye, make sure that they can orient them to where food is, the drink on the right side. Make clock with them. We usually do clock. Tell them the juice is on 12. That means it's right here. Your drink is on 6. That means it's down here. Spoon on 3 on this side. Things like that. Milk on 9. So now they need 12, 6, 3, 9. Divide it up for them. And don't ever assume that the patient knows 1, 2, 3. And don't ever assume the patient can read. That's another thing people don't know. Most of these patients we take care of cannot even read past 5th grade. So don't assume that because you said all this, you walk away, they know what you're talking about. No. You have to be there for them to actually start doing it. That's the only way you know they understand what you say. The patient, most of them cannot read. Don't look at appearances. Some people hair might worth $1,000. They fix their hair, the nail is just $100 for nail polish, and shoe is like a sneaker, like you all know more than I do with this face. Shoe might be $200 sneaker. That doesn't mean nothing. That doesn't mean they know what you're telling them. That doesn't mean they can read. There was a lady in the, I'm always thinking like this anywhere I go. I was on the line to pay for my gas. So the lady was in front of me. She paid for her gas. Then the cashier says, "Which number is your account?" She said, "I'm sorry, I don't have my eyeglasses. I couldn't see." You see how she get away with that? She couldn't see the number. Do you realize how big those numbers are that you're missing? That tells me she cannot read. She may not know 1, 2, 3. So don't assume. Plus, she looks like she's off the street, so that one adds to it too, to me. Early in the morning, she already drinking alcohol, so you don't know if it's alcohol or drug or the way she looks, or she cannot read. But always assume they cannot read. Help the people out when you see that. But I couldn't see it myself because that number is the other way. I could have told them what number it is. But it's the other side. You have to know it before you come in. So there's a lot of things out there, a lot of ways you can be, we can help people, not just when they're in the hospital. Help them so that they don't even get in the hospital. Okay, so what are you going to do about, vertigo? What is vertigo? Dizziness. So again, what are you going to do about that? For precautions, educate them to sit up first before they do what? They get up. If they start feeling dizzy, they need to sit down. They don't need to walk to the chair. This is how I used to teach patients with anemia. Patients with anemia can feel dizzy at any moment of the day because of decreased oxygenation. So anytime you feel dizzy, just sit down. Don't say, "Okay, let me get to that chair." No, you may not get to the chair. So once they feel dizzy, let them sit. Educate them on that because they don't know that. Nausea, anti-emetic. Educate them to take their nausea medicine as ordered. If they don't have any, they need to contact their doctor because most nausea medicine are prescription. Numbness, paresthesia. What are you going to do about that? Patients that have numbness and paresthesia to the extremity because of multiple sclerosis. Affects the feet. It becomes like diabetic. You all did diabetes, right? I heard one of you say, it's kind of like diabetic patient. I like that. Because we have to understand that if you have numbness and tingling because of neuropathy from diabetes, it's no different from numbness and tingling if you have it from multiple sclerosis. It's the same body. It's the same numbness and tingling. The same precautionary measures. Check your feet. Wear covered shoe. Don't put lotion between the toes. Those signs and those interventions is the same thing. Loss of proprioception. What is proprioception? What does that mean? Eh? Lack of knowledge about your body position. You don't know if your body is standing up or sitting down and which particular body you're going to move first. So it becomes severe high risk for fall because you don't even know where your body is. So they don't feel these things. So we need to educate them. Safety again becomes important. Then blindness against safety. Reproductive impotence or loss of genital sensation. Painful heightened sensation for female and vaginal dryness. So what did you come up with your intervention? What did you come up with? Lubricants. Again, some of these things can be very sensitive. Talk to the patient on one-on-one. Do not have crowds or the family. Don't discuss sexual, symptoms around the family. Talk to the patient on one-on-one. So you see how multiple sclerosis affects the whole body. Again, it becomes important we understand this so that we'll be able to know how to take care of those patients. Medication. Multiple sclerosis does not have any medicine. There's no cure for it. Can I erase this? Remember that medication sheet I gave you in the beginning? Please, can you pull that out? Anytime any teacher gives you a paper for that concept, keep that paper for the whole concept, especially if the concept have secondary components to it. Keep that paper because you're still talking about the same mobility. So these patients with multiple sclerosis, they can have what we call immunomodulators. Immunomodulators, like interferon. That's one of the most common medicine given to them. There is no cure for it, though. So what this medicine does, it just prevents exacerbation and remission of the disease. It doesn't cure it. It kind of prevents the symptoms and prevents the patient from having exacerbation of the disease. You can imagine when you have all these signs and symptoms we went over that affect the whole systems in the body and there's no cure for it. So somebody was telling me something during break about the family member. Who was talking about the family member? Can you tell us what you said during break so that everybody will hear?
My sister has what they're calling ataxia. They're not diagnosing it as MS because all of the same symptoms. Insurance won't pay to put her on these meds because she doesn't have a diagnosis, but the doctors think it can help, but she can't pay out of pocket because they're very expensive, but they won't give it a diagnosis.
Okay. So what is the relationship between what she said and what we've been saying all day? It is very, very hard to diagnose. And this is for once in my lifetime, I will support the insurance company. Once in a lifetime. They don't want to pay because there's no diagnosis. I can see why they don't want to pay. I mean, we have to have the diagnosis. We have to have a diagnosis so that they know what they're paying for. So, from all these signs and symptoms, if the sister is having all the signs and symptoms, again, even the book spend tremendous amount of time explaining why it's so difficult for the doctors, nurses, the family member, the patient. Nobody knows what's going on. So, this is one of those. And it's not good for the patient to be lingering like that without any diagnosis and treatment. So what interferon does, again, it modulates the immune system, prevents that attack that the immune system attacks those myelin sheaths to prevent further exacerbation or remission. Prevent exacerbation is the word I'm looking for. Prevent the exacerbation of the disease. It doesn't cure it. They also can have a prednisone. Again, prednisone is what? Steroid. Prednisone or steroid. Other form of steroid. Which is an anti-inflammatory. Again, because it's an anti-inflammatory, it suppresses the immune system. So those steroids are immunosuppressant, again, to prevent that body from attacking itself and to prevent the patient from having that remission, exacerbation of the disease. Prednisone suppresses the immune system. It's the same immune system that it suppresses when you're taking it, whether you're taking it for COPD or asthma, you still have the same signs and symptoms. Because it suppresses the immune system, you need to educate those patients to avoid crowd. You need to educate them to weigh themselves. You need to educate them. It predisposes them to osteoporosis. Remember, it attacks more female than male. It decreases their potassium level, increases blood pressure, fluid retention. The whole thing we went over already before, the same thing. Also, there's another medication, which is also an anti-inflammatory. Cyclophosphamide. It's also an anti-inflammatory. They can have those too. Again, all does is to reduce inflammation. There's no cure for it. It doesn't cure the disease, but it can reduce those signs and symptoms that they're feeling to help them cope with what is going on with the disease. Then the stool softener we have at the back of the paper I gave you. We have Coles. We have, what other stool softener do we have? From this paper I gave you, what other stool softeners do we have? Huh? Glucosate or Coles. Then we have Dulcolax or Cinecot. Then we have the laxative that are osmotic, milk of magnesia or Lactulose or Miralax. So these are just to help those patients because they might have constipation from immobility too. Because once they start having all these spasms, ataxia, and having exacerbation, they're not going to be able to get up and ambulate. Okay, so let's go over the slide and see what's going on there. Multiple sclerosis. It is a chronic progressive degenerative disorder of the central nervous system. We already talked about that. Characterized by the myelation of the myelin sheath, which is what covers the nerve endings, so it damages that. Disease usually affects the middle-aged adults, mostly young men, women, from age 20 to 50 years of age, like your stepdaddy. Women are affected more than men. Disease progress consists of loss of myelin, because it's that myelin that covers the nerve ending. As it attacks the myelin, it reduces the amount of myelin that covers the nerve endings. It predisposes those patients from having all those signs and symptoms we talked about. It has vague symptoms. That's what we've been reciting all day. Vague symptoms, difficult to diagnose. It has period of exacerbation and period of remission. Common signs and symptoms, they have motor problems. We discussed all that already. They have ataxia, diplopia, sensory problems. It's more explained in the next page. Motor manufacture, weakness and paralysis of limbs and trunk. They have diplopia, double vision, having problem with scanning their speech. They cannot come up with the word to say. Spasticity of muscle makes walking more difficult, so they end up having ataxia. They cannot coordinate their movement. Sensory, tingling and numbness to lower extremities. Fall becomes an issue. Educate them, wound. Let them wear cover shoe. Vertigo and tinnitus. Balance again becomes a problem. They can easily fall. If they start feeling they're about to fall, let them sit. Don't try to get to your destination or where you have somewhere to sit. Chronic neuropathic pain. What is Littmann's sign? Littmann's sign is like electric shock going down their lower extremity. So from that numbness and tingling, sends like electric wave shock to their lower extremities. That's how they feel. That's what Littmann's sign is. Cerebral manifestation, it affects the cognition. So, nystagmus, double eye movement, ataxia, difficulty coordinating their movements. Dysarthria, atria, articulate, dysarthria, difficulty articulating words. And then dysphagia, difficulty swallowing. It affects the muscle of swallowing. So we have to watch those patients closely for aspiration. They have bowel and bladder problems. Constipation, we went over that already. Increase fluid, give them stool softener, ambulate them to help to counter constipation. Spasticity of bladder, small capacity for urine can lead to incontinence spasticity, so it keeps squeezing. They have less room for urine to accumulate, so that can lead to urinary incontinence. Flaccid means large capacity is flaccid, so it stretches out, then it accommodates more urine, predisposing the patient to urinary retention. So scan the bladder, do in and out fast. Then monitor intake and output. You're probably going to have to send urine for UA and CNS to check for infection. Sexual dysfunction, so look at that emotional aspect of the patient. It can cause, we already went through this during the group activity. Talk to the patient on one-on-one because it's a private issue. Cognitive manifestation, difficulty with short-term memory. Those patients might remember what happened 2 weeks ago, but they may not remember what you told them an hour ago. They have problem processing information. You tell them something, you think they understand it, they may not necessarily understand what you say. Planning, you have to plan, give them more time to do things. Visual perception, again, make sure they can see what you're doing. Put that food in front of them, make sure they can see it before you leave the room, because they have a double vision. Word finding, they cannot find their word, so they don't know what to say next and how to say it. They couldn't pick up, formulate a word or something. Speech what? They kind of related. They're related. They scan their speech. I need you to give me water. So everything is kind of with emphasis. They kind of related a little bit. They all issue with making a sentence and formulating words and talking about them. Emotional manifestation, anger, depression, and euphoria. They might be having anger, but they might just all of a sudden start being mad over something. Does he do that? They can just be mad over nothing. You didn't say a word, they just start fussing. It's just the frustration and what's going on in their body is making them feel like that. So have patience with them. Medication, corticosteroid. It treats acute exacerbation by reducing inflammation and the edema. It does not really cure the disease. It doesn't affect the ultimate outgo. It just kind of reduces the signs and symptoms, but it doesn't cure it. Immunosuppressant therapy, beneficial for the patient, again, to prevent those relapse and again, prevent those signs and symptoms from being too exaggerated. It doesn't cure the disease. Interferon is one of the most common ones that is given for the patient to slow that progression. Again, it doesn't cure the disease. Before you give this natalizumab, before you give that, because it is also an immunosuppressant, this natalizumab is an immunosuppressant. Before you give that, that means none of these is working before you give that, because it affects the brain. It has a very bad side effect with the brain. Because it attacks the brain as one of the side effects, it's usually the last to be given when nothing else works for the patient. Muscle relaxer like baclofen is one of the most common ones. Muscle relaxer is in that paper I gave you too, baclofen. Anticholinergic, I don't think we have to worry about it. That's too many stuff. So not too many medications. But they usually get that muscle relaxer because one of the major problems is those spasticity and muscle problems that they have. Physical therapy. Get physical therapy involved to relieve that spasticity that they have. Improve coordination. Train patient to substitute unaffected part with affected part. When a patient is exercising, let's say they have left-sided weakness. No, let me use like right hand. Most people are right-handed. And believe it or not, most often when patients have stroke, guess which side that's paralyzed? The right side. The right side that they are eating with is always the one that's paralyzed. And most patients that have right-sided weakness, they have problem with speech because it is the left side of the brain that's affected. The left side controls speech. So once it's affected, those patients are going to have right-sided paralysis, hemiparesis, and they always have problem with speech. So that means they're going to have problem with swallow. If you have problem with speech, it affects your swallowing reflex. So they need to now learn how to use their left hand to feed themselves. So that's another thing, physical therapy and occupational therapy. So they need to substitute with unaffected limb. Assist patient with dealing with anxiety and diagnosis. During acute exacerbation, prevent major complication of immobility. They need still to get up and ambulate. Space out that activity so they can start ambulating. Focus on teaching patients general resistance to the illness. Avoid fatigue, extreme hot and cold exposure. Now, hot and cold, remember they have neuropathy in their lower extremities. They can easily get burned, right? So we need to educate them. When you're feeling for hot water, what do you use? Your arm, don't use your leg. These are the type of patients that go outside there in the, we don't have snow on this side of the world, thank God. They can go outside in the snow, they don't even know they get the cold frostbite there. Because they don't feel anything. They don't know they've been standing on the heap of cold for a long period of time. So we need to watch for that. Good balance, exercise, nutrition. Teach self-characterization if necessary. Because of that muscles flaccid. If Kegel exercise don't help them to pee, then they're going to go home and fall. So we need to educate them how to do, or do in and out on themselves. The doctors are preferring for patients now to do their own in and out than send them home on foley. If they are awake, alert, and oriented, they do the foley in and out themselves. And most patients like that. And sometimes they involve the family to help them too to do that. ALS. ALS doesn't have much to do. That's why we have a different, it's not even in the book. It's one sentence in the book. So, how many of you know somebody who has ALS? Huh? Anybody? How can you live in New Orleans and don't know anybody who has ALS? I was about to say. Huh? You don't know him? You're not from New Orleans? We're about to send you back to where you came from. I didn't say you know him personally. At least I've heard about his name, right? You don't know him personally. But at least you know enough from the TV. If you watch the Saints game. But Lord helped them yesterday, right? We don't even want to talk about that. Okay, ALS. ALS is anybody know somebody who have ALS? Nobody? Yeah, okay. He was on what? Speech. Okay, he was on a chair, so wheelchair, speech problem, right? So what else did you say? It is a disease that affects the musculature of the body. It causes a degeneration of the muscles with a lot of spasticity, a lot of spasms. It is a progressive weakness of the muscle that leads to paralysis. It is a progressive weakness of the muscle that leads to paralysis. There's nothing that stops that progression. It doesn't have medicine to eat. life expectancy is 3 to 5 years. It affects men more than it affects women. So because it's a disease of the muscle, they have problem with ambulation. So it progresses where they be wheelchair bound. Because it's a disease that affects the muscle, their cognition is intact. It does not affect cognition. Their eyes are intact. But it affects their speech, it affects their respiratory system, it affects their extremities. Anything that moves, like the limbs, upper and lower extremities, it affects that. So those patients ends up being in the wheelchair. It is a progressive disease. That means you have to keep going. Nothing slows it down and nothing stops it until it gets to paralysis. So they're going to get to being paralyzed. They're going to end up being in the wheelchair. Steve Gleason is one of those exceptions where he has lived more than 5 years, to the best of my knowledge. But look what he got. This man is in a, I don't even know if that's, it's like playing in a wheelchair. This wheelchair has everything on earth. He has the TV screen whereby he writes with his eyes. Now tell me how many people that can afford that? Just tell me. So, but from what I understand, he worked with Bill Gates. Bill Gates donated that to him or something. So, he works with his eyes. He can write full sentences with his eyes. He still smiles. Even with the paralysis and the airway compromise, because he lives in respirator that he carries around with him. How many people can afford that? He lives with respirator. He carries it along with him. But he still have that cognition that's intact. He makes full sentences, smiles. Yes. Oh, okay, that's good. That's good of him to do that. Yes. Wow, that's nice. So where is the foundation? In Meadow.
St. Margaret. It's like off a canal.
Oh, look where the location is, yo. Off Canal. In the mid-city here. Now you're kidding me. How many people? I don't even know it's existing. Who? Okay. Santana. Which one is Santana again? Oh, the one that left? What's her first name? Oh, I know Robin. Okay. I don't know. I just don't know her last name. I know Robin. Yeah, she's nice. Robin is one of those students advocates. That's why I love her. She's one of those. Okay, so you see what you said? So there is group. Those people can join group. See now their life expectancy looks like it's stretching out. But again, there's no cure for it. But they do take what is this medicine? Ridazole. Ridazole or something? Riluzole. R-I. That is the most common medicine that's prescribed for them. Again, it doesn't cure the disease. It just helps to slow the progression of it. But eventually, those patients that are in that area in the nursing home, are they paralyzed or not? They are paralyzed because the disease progresses to what? Paralysis. Remember, when you're talking about paralysis, it's paralysis of the muscles. And these muscles include the airway muscle because the lungs uses a lot of muscles. So those patients end up dying with respiratory failure because of a problem with their lungs. It will affect everything. It affects everything, but most often the lungs. Probably the lung before the heart. but the book emphasizes a lot about the lungs. Of course, airways, though, airways that will bring the oxygen to the lung, to the heart and everything. So, eventually it leads to paralysis. So those patients always have problems with that. So this is the patient that you need to start talking about living well. What is living well? What is living well? Living well is what the patient will make on her own. So let the doctors and nurses know how to care for them. That's the patient, when they're still intact, their brain is still intact, they can still reason well, they can still do everything they're doing. They're going to tell the nurses and doctors what life-sustaining procedure they want to do or not done. This is the patient saying it himself. We need to start discussing that with those patients because it's going to lead to paralysis. And you don't want to wait until when they are incapacitated to do that. What is a DNR? Do not resuscitate. Who comes up with that? The patient. The patient can say, if I stop breathing, don't do anything. Let me go. Right? But when patient is incapacitated, what is the word incapacitation mean? Huh? Means they're not able to do things the way they want to do it. That means the way they're thinking is different now. The way they're moving, the way they're doing things is different. They are very sick now. They can do what we call durable power of what? Attorney. What does that mean? Yes. That means they're going to appoint somebody who will be making decisions for them. And that somebody could be a family member. Or may not be a family member. Could be anybody. So that person will be the one that will be making decision for this patient because now this patient cannot make decisions for themselves. So living well and advanced directives are kind of like the same thing. Telling them what he wants to be done or not being done. So this patient, why are we discussing this? Because this leads to paralysis, and when we're talking about paralysis, we're talking not just physical paralysis of movement, we're talking about respiratory paralysis. And it's heading there. It's heading to respiratory paralysis, and most of these patients ends up being intubated in the hospital, being on vent. Vent does not cure it. The patient will never come out of the vent, so most of them will opt not to use the vent, not to go through vent, because it's not going to cure the disease, and they will never get better from it. So why go through that? So it is a disease that's progressing towards that. You cannot stop it. Therefore, it's good to start talking about this living well when they can still have their mind intact, or advanced directives so that we know who's going to take care of them when they're already beginning to be incapacitated. Durable power of attorney when they're already beginning to be incapacitated. Get the family member or somebody they can dedicate to do that. So, the riluzole becomes the only medication you can give them. It doesn't cure the disease. It just slows the progression of it. There's no cure for that either. So, ALS and MS, there's no cure. A patient comes to the hospital with multiple sclerosis, or patients that have herniated disc have multiple sclerosis. On post-op day 5, patient is having problem breathing. What will the nurse do? A, we position the patient. B, teach incentive spirometer. C, give oxygen as directed. D, apply SCD pump. Patient with multiple sclerosis have herniated disc. Or patient with multiple sclerosis have laminectomy for herniated disc. Because you can have two diseases. Nobody comes to the hospital anymore with one thing. On post-op day 2, the patient was having difficulty breathing. What would the nurse do? Reposition the patient. How many of people said A? Reposition the patient. 1, 2, 5 people. Teach patient to use intensive spirometer. Give oxygen as directed. I might just say like 11. Apply ACD pump. Okay. So, what is the patient problem? Patient has what? If they're having difficulty breathing, if I reposition the patient, well, I hope you won't be that close. I see why you keep reposition. Because I say patient have difficulty breathing. If I have said, instead of difficulty breathing, I will say, I will replace that with shortness of breath. Will that make a difference? Patient with multiple sclerosis had laminectomy for back surgery. 2 days post-op, patient was having shortness of breath. What would the nurse do? Patient was having shortness of breath. You position the patient, anybody? Does it make a difference now? Huh? Jennifer, you're still not sure? Okay, so what does the patient have? What is the patient issue? If I reposition the patient, will it correct shortness of breath? It will not. Will I be teaching a patient that can breathe to use the intensive spirometer? Always remember, you cannot teach patients anything. When they are in pain, you can't teach a patient anything when they're having issues. If they're having shortness of breath, you can't teach them nothing. They are in severe pain, you can't teach them a thing. They will never pay attention. So anytime they're having issues, they're not listening to you. The issue that they have is taken away. They are thinking. They're not listening. So pay attention to that in general. If I give the patient oxygen, will it stop shortness of breath? Yes. What is causing shortness of breath? From surgery. Post-op day 2, lack of oxygen. The patient probably having pulmonary embolism, but right now we know it as shortness of breath. We're not going to add anything else to it. We're going to give that patient oxygen in an attempt to neutralize that shortness of breath. The patient is going to have ACD, but he has nothing to improve the shortness of breath the patient has. Yes. I hope you won't be that close, but I will elevate first and give oxygen. But we try not to do that like that because, it's kind of too close. But I will elevate the bed, then I give oxygen. Any questions with that? Okay. A patient with ALS came to the hospital. Upon assessment, the nurse explained to the patient that you do have ALS and that this disease progresses to paralysis. And when it progresses to paralysis, you might have difficulty with everything, those signs and symptoms, communicating or breathing. What would the nurse expect? What would the patient do first? What would the nurse ask the patient to do first? A, DNR, A. I don't know why I circled it. A, DNR, B, living well, C, durable power of attorney, D, I don't know what else to say, so I must just say HIPAA. So, what do you think the patient needs to do first? Oh, Lord. Anybody remember the question? Patient is diagnosed with ALS. The nurse is newly diagnosed ALS. The nurse explained to the patient that the disease leads to paralysis. Well, let's go down the list. How many of you say DNR? 1, 2, 3, 4. 4. How many of you say living well? Like, I'm going to just say 15. Durable power of attorney? Of course, this don't mean nothing. Yes.
The nurse wouldn't suggest it.
This is the patient that's newly diagnosed. The patient just came, just hearing about this diagnosis the first time. Remember again, we don't go by what we already know that is happening out there. We go by what this question is asking. The nurse will not even ask the patient to sign the DRR. The doctor will do that. So this is something that's newly diagnosed. The patient knowledge, the brain is still intact. They understood what the nurse is saying. So the patient needs to do what? Do a living well. Durable power of attorney is when they cannot make those decisions themselves. Then we have somebody else making the decision for them, right? Oh, ALS. Another name for ALS is what? Lou Gehrig disease, because it's the name of the person that discovered that disease. It's a progressive weakness, muscle wasting, spasticity, so they have problem with coordination and movement again. The cognition remains intact. If you remember Gleason, he still is able to use his eyes to write correct sentences. There's no known cure for it. They have fasciculation. What is fasciculation? Muscle twitching. They have cramps. So you can see it affects a lot of muscles. Anytime you think of this muscle and ALS, think respiratory problems because it affects the muscle of the lungs more. They have difficulty chewing and swallowing. So it becomes important to pay attention to their swallowing so that they don't aspirate. There is no cure. Drug to treat symptoms alone is riluzole. Monitor LFT, liver function test for that. And the interferon also monitor for liver function test for those. Optimal function is the goal. Collaborate with speech therapy, occupational therapy, like we've been talking across the mobility. Nutrition consult, because they're having problems swallowing. Respiratory therapy with the monitors and breathing. And then discuss hospice. Any questions?